What gives me hope is that I feel a strong sense of agency in creating a future, because traditionally things have been handed to us of this is how things are. You get credentialed with insurance, you see patients in these 20-minute slots. This is the technology that you get because it's always been like that. What I'm seeing a lot now is a lot of people are becoming savvy in navigating the business world. They're becoming savvy in navigating the technology and realize that there's a lot of bloat and that there's ways to do it ourselves. And I do think that there's a strong movement towards independent practice.
When I was writing about primary care, really struggling to come up with meaningful and pragmatic solutions, sometimes I'd force myself into a thought experiment. And I'd imagine someone came to me and said, you get to do one thing for primary care, and one thing only. So what would it be? In my little thought experiment, I seemed to have an easier time figuring out what I wouldn't choose. I wouldn't choose value-based payment models, nor the dissolution of the RUC, nor more loan forgiveness programs with the hope of growing the pipeline. Not because these interventions aren't important, but more because I was trying to get at the crux of the challenge, a crux that's as spiritual as it is pragmatic. And so when I was listening to Paulius Mui, the young family physician you just heard from, something clicked for me. Partly it was the optimism in his voice about the future of primary care, but even more importantly, it was his sense of his own agency, a belief that he could help make primary care better. And so when he mentioned the movement toward independent practice, I thought, that's what I want for primary care, more than anything else. A restoration of autonomy, the power to innovate in ways that might better meet society's evolving preferences, and a return to independent practice. The kind of independent practice young primary care physicians, like Paulius Mui, are increasingly excited about. The kind, of course, that have become a rarity in our massively consolidated, corporatized healthcare landscape. Now, I know many people would say, why not just choose money? For independent practices to be financially solvent, you obviously need your revenue to exceed your overhead. And the loss of many independent traditional primary care practices certainly reflects, at least to some degree, financial constraints. But today we're going to be talking about a few types of independent practices that exist outside the traditional healthcare system: concierge medicine and direct primary care. These practices, of course, also need money to function, and we'll get into some of the details about how they generate revenue. But again, what I'm going after here is more spiritual, and money, at least in our traditional healthcare system, tends to come with rules. Rules that force you to prove your value in a way that's been decided for you. This detracts from physician autonomy, but it also may detract from what matters to patients. Because if the growing market for concierge medicine and direct primary care tells us anything, it's that a lot of people seem to value something that primary care, under its current constraints, is struggling to give them. I'm Lisa Rosenbaum, and this is Not Otherwise Specified, from the New England Journal of Medicine. Before you hear from our guests, I want to provide some basic definitions about concierge medicine and direct primary care. Concierge practices charge an annual membership fee that can range anywhere from $2,000 to $100,000 a year. And in addition to the annual fees, concierge practices also typically bill insurance, though there's some practice variation. Direct primary care, on the other hand, by definition, doesn't accept insurance. Members typically pay a fee that depends on the practice and also on the local market, but it's usually between about $80 and $150 a month. Panel sizes for both concierge and direct primary care practices vary depending upon the physician and the annual fee. Generally, though, the more physicians charge, the smaller the panel. But I think it's fair to say that in both types of practices, people are paying for the promise of access to their own physician, the type of access that's become less available to patients in large health systems. Patients obviously don't like that, but neither do doctors. Katie Brang is a family physician who alongside her husband started a direct primary care practice in 2022. She initially practiced in a private practice in northern Wisconsin, and then she spent 9 years practicing primary care, as well as teaching residents in a private equity-owned system in Lafayette, Michigan. There was a lot about the work she loved, particularly getting to teach trainees and to work in both the inpatient and outpatient settings. But at some point, some of the harsh realities of primary care set in.
The reasons we left, so many reasons, but one of the big ones is that even though I had this small practice, I was still doing 15-minute appointments. I mean, I still needed to see a lot of people in my half days. And I had this one moment where I was running behind, always ran behind. You could see my old reviews. Dr. Brang was an hour behind. I'm like, yeah, that's probably right. So I was behind and somebody needed more time than I had to give them. And I remember telling them, I can't stay here any longer. We have to do a follow-up appointment. And I felt really bad about that because I also knew how far out I was booking. And I just wanted to practice medicine differently.
Like many DPC physicians with whom I spoke, Katie was also very sensitive to the financial challenges her patients faced in the traditional insurance model.
People recognize that this whole one problem, one visit, it's just not ideal. They come in for their blood pressure, but their shoulder hurts too, and you don't have time for that. So then they have to come back in 8 weeks and do another copay for their shoulder, and then another one 3 months later for their foot. I mean, it doesn't really fit with how people want to get their care. And if they can get it all done at once in one visit, and then very easily have quick follow-ups later to see how they're doing, people love that. And it saves them money. Because if you have a high deductible plan, every visit that's not your physical, you have to pay for that. And so it lowers the bar to come in also, because people like to wait. If they're going to pay $300 to see me, they're going to wait till they absolutely need to see me. If they've already paid their, $90 a month, they're going to come in when they're only a little sick. And maybe we can head it off before they get really sick, and then they never have to go to the ER. And this data is really hard to capture. How many people do we keep from going to the ER because we saw them early? I don't know. Maybe they were going to get better. But prevention's always hard with that. How do I prove that the care that I'm giving is going to lead to better outcomes? I don't really know how to do that. That's always been family medicine's problem.
I personally have a really hard time understanding why we can't just acknowledge that having a doctor who knows you through your life is just a good thing, whether or not it shows up in metrics. Increasingly, though, that continuity depends upon physician goodwill and an expectation that PCPs will just work all the time.
Both my husband and I we were kind of having these conversations of, is this our life? Are we going to spend the next 20, 25 years doing this? In this basement clinic doing this thing where we're never seeing our kids. I mean, we had this fabulous nanny for 8 years and she was amazing and made our lives work, but we never saw the kids because we were working early and late and all of that.
Katie and her husband sat down with some of their best friends, both of whom had started traditional insurance-based independent practices. And one of their friends said,
"You need to look at direct primary care." And she loved the practice she'd started. It was going great. But she said if she had to do it all over again, she would look at that. And we took a weekend and we looked at direct primary care and we said, this is absolutely what we're looking for because of the time that we were going to be able to spend with people and the changes that we'd actually be able to make in people's lives were really only going to fit in a model where we had more time.
They spent a weekend learning about direct primary care, which has this huge community of physicians all eager to help one another. And then they just made the leap. Katie's husband went first, and Katie soon joined him.
We kind of joke that our direct primary care practice is like blue-collar concierge because our monthly fee is, for most people, under $100, and that gets you access to either myself or my husband, all hours, which people respect, and gets them same-day, next-day appointments, long appointments, lots of access to lifestyle medicine, preventative care, and a lot of the family med procedures that we're trained on, we actually do, and we include those in the cost. And it also gives people access to low-cost labs, and if they need it, low-cost generic medications. So it's really an excellent deal for a lot of people, especially those with high deductible health insurance and those that want more time with their doctor.
Both DPC and concierge physicians love having time with their patients, especially when it comes to aspects of primary care that can take more time to be done well, like counseling about lifestyle changes.
We spend a lot of time in primary care saying we want to do prevention, but we don't pay for it. And so when you don't pay for it, it doesn't get done. And so you'll see someone who's pre-diabetic and you give them a few minutes of nutrition counseling and maybe you'll see them in like 6 months. Whereas now I can identify my pre-diabetics quickly. We can get on it and actually do something about it and reverse their A1C rise. It's so exciting. And we also get people who are motivated to change because they're paying for it. And I think that's also helpful because they come in and say, I want to do something, help me make changes that will stick. And that's exciting.
I had a hard time understanding how, without insurance, primary care could do all the things it usually does for patients. Ordering colonoscopies, for instance, labs, medications. So a few clarifying points. Most patients in DPC practices still have health insurance. So all these routine medical needs are covered to the extent any insurance covers them. But the other thing that's notable is a lot of DPC practices contract with labs, like Quest, to offer discounted rates on things insurers might not cover. Here's Katie again.
The other thing is that I can't discount the value for patients because it's not just that they're paying to see me. By being a member of my practice, I get them labs really, really cheap. So I have a lot of patients who need monitoring for XYZ problem. And if they go to the hospital lab, it can be hundreds and hundreds of dollars for a thyroid panel or whatever it is that they need. And I can get that stuff done for $5 to $10. Well, over the course of a year, I'm saving people hundreds of dollars. And that's a big thing. The other thing we can do by having control of the labs we order is we can order things that we think are necessary that the insurance company doesn't think are necessary. And a lot of those are screening things, A1Cs in a 45-year-old. Insurance company's not going to pay for that, but it's $5. We can do that every couple of years. And I've caught so many pre-diabetics that way. And the other thing, people make these big changes and they want to see progress. I can draw their labs again. They're paying for it. And it's not that much, and they can see progress in their LDL or whatever it is they're working on. And that's really powerful for people to see change. When we say the insurance company doesn't pay for this, you're paying for it. People are like, yeah, $5, I'll pay for that. So I think that gives a lot more power to the consumer as well.
Of course, so much of this, whether in DPC practices or concierge, is about giving power back to the doctor as well. Caroline Burks is a primary care doctor who now practices at Synergy Health, a Boston concierge practice. Prior to joining Synergy, though, Caroline practiced for over 20 years at Bullfinch Medical Group at Massachusetts General Hospital. I trained at MGH and also had my own primary care clinic as a resident at Bullfinch. And even though I knew from the first day of medical school I wanted to be a cardiologist, if I had chosen primary care, I would have chosen to practice at Bullfinch. And for several years, Caroline loved it there too.
I loved that I had longitudinal relationship with my patients. I loved that I was still at MGH and could round on my inpatients and be involved with subspecialists and do as much as I wanted in each area that I felt comfortable with my patient. So, if I knew more about cardiology or GI, I could dig a little deeper there. But if I needed more help in rheumatology, then I would refer patients out sooner and rely more on my subspecialty colleagues. So I felt like it just was a job that I could get so much out of. Loved getting to know my panel of patients and acquire new patients and have people say, oh, will you see my husband, my daughter, my mother, and bring new people into my panel and sort of see families, see people through illness, see people through, the ups and downs of life, having children, getting married, breaking up with a boyfriend. And it always felt like some of my visits could feel almost like seeing a friend, but I always fell back on knowing that building those relationships with people and getting to know them in those times of wellness really set me up to be able to take care of them when something came up because they trusted me. They knew that I knew them. They knew that I had their best interest at heart.
In 2016, Caroline became a co-director of the practice with her colleague Lisa, but it was a hard time for the practice.
Several nurses left, several doctors left, mostly to go into concierge medicine. And I remember thinking that I would never be a concierge doctor, that I'm Canadian and I am a socialist at heart. And it just felt like I would never take care of a subgroup of patients that could pay me to be their doctor.
But over the next 8 years, the practice struggled under all the forces that have been universally tough for primary care: the EHR, COVID, and exploding inboxes. More than anything, though, there was a striking loss of autonomy. Here's Caroline describing what happened when the practice was forced to change its reimbursement from an RVU-based model to a salaried approach. And I know a lot of people hate the RVU-based system, but as you'll hear from Caroline, salary-based reimbursement has its downsides as well.
I had to meet with every doctor in my practice, and my bosses came into those to look at every single person's individual schedule and map out how many patients they needed to see each session. And so they started to micromanage our schedules, and it started to feel very punitive and very much like we were not professionals anymore. We were not viewed as adults that could make the right decision and show up to work, even though we were. It just felt like they were missing the whole point that, we did actually care about not being counted on the little widgets that we deliver every day, how many patients we're seeing. And people also resented not getting any extra compensation when they went above and beyond.
The other requirement in this new model was to have a certain panel size. But as more doctors left, the size of the panels of those left behind just kept growing.
So there was talk about, how do we handle the increased volume? So they talked about everything from like charging patients for patient gateway messages, which of course they decided not to do because that's a little bit ridiculous, to having central nurse practitioners answer all of our patient gateway messages. And this was something that just really struck me when they started talking about this. And this was kind of in the stage where I was starting to get pretty disillusioned with how leadership wanted me to be handling our practice that had more and more doctors leaving and more patients without doctors and more patients on each doctor's panel. So I talked about having nurse practitioners who weren't even in our practice answer all of our patient gateway messages. Similarly, they said we could have these same nurse practitioners write all of our result letters. So when they started talking about this, I was like, wait, these are my patients that I've known for 20 years that trust when they send a message in to Dr. Birx that Dr. Birx is reading the message and Dr. Birx is replying to the message. They can show me all the data that ChatGPT can answer my messages better than I can or whatever else. I just don't believe it. I'm sorry. And not that I think I'm any more special than anybody else, but I think there's some messages that are pretty generic and somebody else could answer. But oftentimes we know things about our patients. I know this patient never complains, and now they're writing me this message with these symptoms, and I'm concerned. This patient has had these symptoms on and off forever, and I know them, and we've evaluated, and I can send this message that I'm not concerned. This patient, it may not say it in the record as explicitly, but I know they're immune suppressed, and so I'm going to treat them differently than what somebody else might think about doing. And so this idea of having a nurse practitioner answer all my patients' messages, I remember having a meeting where that was discussed, and they were like, wouldn't it be wonderful if you came in the morning and your in basket was empty? And I remember looking at my boss and saying, wow, that would feel like coming in the morning and having my email be empty and having somebody else have responded to all my friends and me have no idea of what was said. Because they said, like, there's no point. They don't want us like rehashing the message that the NP did, because then I'm just redoing the work and it's twice as much work because I got to look at the message, look at the NP's reply and figure out if it's the right thing, right? So it just would disappear.
I reached out to the current medical director at Bullfinch, Dr. Karina Spencer, to confirm two things. First, the transition to centralized APP management of in-basket messages, and second, the changes in the compensation model. While both are true, Dr. Spencer believes that these changes have actually been beneficial. When it comes to the in-basket, issues that can be addressed only by the PCP are still routed to the PCP. And while all payment models have trade-offs, the salary-based compensation has been beneficial in some ways, particularly for young physicians. But I still also understood Caroline's concerns, so I asked her what finally broke her, meaning why she decided, despite her Canadian socialist origins, to leave for concierge practice.
I was basically turning into an urgent care doctor. And I didn't want to be an urgent care doctor, right? That message was kind of like, when the patient's in front of you, they're your problem. Otherwise, they're not your problem. And I'm like, wait, they're my primary care patients. I am their doctor. I want them to be my problem.
The experience Caroline is describing, which is particularly common in large health systems, partly reflects misaligned financial incentives. Leaders of large health systems often see primary care as a so-called loss leader, meaning a money-losing access point to more lucrative services. And that's why it's easier to blame CEOs of large health systems for the neglect of primary care. But these CEOs, in many instances, are just responding to complex financial incentives and social forces that they didn't create. And in fact, as one of our listeners, Dr. Rob Chamberlain, pointed out to me, some health systems really are investing more to support primary care. Rob is Chief of Population Health and Primary Care at Maine Health Medical Group. And one point Rob made that's relevant to this episode, but also to the whole future of primary care, is that we need to be a bit more precise when we blame the so-called system for underinvesting in primary care. So here's what Rob said. The focus of anger for chronic underinvestment in primary care is often directed at the, quote, system. And by the system, most PCPs mean the health system. Yet I would offer that the system that's underinvesting primary care is society. It is the ruck. It is the fear and lack of imagination of payers. It is a lack of social services and investments by the government. Those systems are underfunding what we need for our patients to be healthy. But in fact, the healthcare systems are often investing many more resources in primary care than they did years ago. Integrated behavioral health, clinical pharmacists, complex care managers, etc. We had none of these 20 years ago. And yet it's not enough in the face of doing more in less time. Until those financial incentives are addressed on a societal level, my own sense is that we'll continue to see a PCP exodus toward non-traditional practices that allow physicians to practice in a way more consistent with their values. Here's Eric Swagel, a primary care physician who co-founded the concierge practice Private Medical in San Francisco. He explains how the concierge model realigns the incentives.
The encounter-based, episodic, volume-oriented model of insurance-driven care was and still is largely predicated on like someone having to present to you either face-to-face or now remotely for some amount of your time in which you're tasked with understanding their issue and coming up with a plan and documenting that in a way that lets you get reimbursed and doing all the things that actually make that plan happen, from creating orders, sending orders, etc. And it leaves a lot of that after to the patient and really deprives you of any time for thought, coordination, or assisting the patient in enacting that plan. Unless and until you start delegating those to third parties that have additional charges and additional scheduling needs, or you elaborate systems within your office to sort of do those things at some additional charge or a cost to yourself, and you're trying to hustle to sort of like make that a financially viable product. And you're trying to operate at a way that efficiently lets you maximize your element of that care and take parts of that care that maybe you can do best, but are sort of below your license or below your pay grade and give them to other people who you have to hire and support and train and all those things. And so the system becomes like super elaborate and difficult for you, the doctor, to administer, but you're not really like adding much to the patient experience or to their healthcare. So having the time that a lower volume of patients, which is enabled by a concierge model that the patient commits to you, lets you take on all that stuff and do it in a way that's organized and efficient and adds value, even if sometimes you as the doctor are choosing to do some of that coordination work. And I would argue sometimes you know how to do it best.
Part of what was so striking to me as I learned about these new models is that they're essentially new ways of doing an old thing. Here's Caroline again explaining what patients describe wanting from a concierge practice.
And so many of them, they just want your time. They want to know that you're going to look out for them. They want to know that when they send a message, you're going to answer them, that if they have a problem, they can call you. This is all the basics of what a primary care doctor should be.
And concierge practices also rely on teams. But it's clear to the patients that the teams are really working together rather than fragmenting care further, as may happen when you have NPs at a centralized call center responding to messages.
When a patient of mine sees my nutritionist, I'm sending a message. They're writing back to me. We're communicating in the hallways about what's going to work for this patient. It's not that we're having fragmented care and lots of different people doing it. It's that we're working together. And that's really what patients want. I have 2 nurse practitioners in my practice who are amazing. It's not that I think nurse practitioners are bad. I think nurse practitioners can be wonderful. I just don't want them taking a part of my patient's care when they're not involved in the care as a whole. Patients really just, that's what they're looking for. They're looking for somebody who knows them, who cares about them, who's invested in them.
As undervalued as traditional primary care has been, the growth of concierge and DPC practices suggests that people are willing to pay, sometimes a lot, for this type of personal investment. One recent comprehensive analysis by Jane Zhu and colleagues found that these practices grew by 83% in a recent 5-year period. And while a growing proportion of these non-traditional practices are actually also part of corporate entities, those who do remain independent are using their freedom to innovate. Polly Ismui, who you heard from at the beginning, is one of those young, innovative physicians. He's a family physician who's building a part-time direct primary care practice that's purely virtual right now. So I asked him what a new patient visit might look like.
So let's say I'm establishing care with a new patient, right? They sign up for my practice and I am able to get their records from all the different health information exchanges so that by the time I have my first meeting with them, I have already received a lot of the prior medical records that have been kind of prepped and summarized for me. So that's a really cool part. I don't need to kind of regather a lot of history from the get-go. And then usually in the first visit, I just get to know them. I don't really try to go through a specific checklist. I just get to hear their story in their own words. And I block off an hour. We don't need to, rush through time to make sure we get through an agenda unless the patient has something active going on. So there was a patient who had run out of their thyroid medications, have not had labs in a while. So that's a pretty actionable thing to focus on. So I can queue up the labs, order them, figure out how to adjust the dose based on the results when they come in. And we get to text in between visits. So sometimes if it's a quick question or something clarifying, we don't need to jump on a video call or anything like that. Basically get to do a lot of care asynchronously. And the patient can be at work, they can be on the lunch break or commuting or something like that, and they're still able to communicate with me.
So let's say, for instance, something like blood pressure, which is one of the things, obviously, that we all think about, not just in primary care. How do you measure blood pressure?
Yeah. So for patients who really are tight with cash and cannot get their own blood pressure cuff, I recommend that they go to their local grocery store. So usually like Walmarts and other places have different blood pressure machines. And I ask them to take a photo and just send it to me what the reading says. Another patient that I had, I recommended that they get a cuff. I think it was like $35. And I walked them through how to measure it while we were on a visit, keeping their arm at a heart level and make sure they like have rested for a while and so on. And they just, turned the camera to the blood pressure cuff. We looked at the reading together and it was actually elevated. So I had them repeat the process after our visit and, send me different readings throughout the week.
I could understand how virtual care might work for some chronic diseases, but I wasn't sure how care would play out for someone with an acute problem. So I asked Paulius to tell me how he'd manage a 65-year-old woman with diabetes who texts him that she's having chest pain.
I think that's a really tough situation. So like in my clinic, right, I would have to figure out how much do I know about this patient? Have we done anything like that before? For things like chest pain, I think with someone who has risk factors that are worrisome, I would help them triage appropriately. Would they have gone to urgent care locally which might have not the right resources? Like should they go straight to ER? And when is it appropriate to wait and see how things happen over the next, few hours? Because do they have a history of a lot of anxiety related to chest pains? And they've had it checked out last week, exact same presentation. So I think there's certain things that are still, you have to think about the risk factors and the trade-offs, and you have to educate the patient of what are the pros and cons of seeking care in the ER versus waiting and seeing. And I mean, for a case like you described, I think normally without additional data, chest pain obviously would be indicated to get a more escalated evaluation.
How do you afford this? Part of what is prohibitive for a lot of physicians who want to do independent practice is the cost of overhead.
So when I'm starting up this practice, I do this part-time. So saved up cash from before to basically bootstrap this so that I don't have to be worried about making ends meet. And if you think about how traditional DPC charges, so like let's say on average, if a direct primary care membership is around $100, when these practices ramp up, they tend to have about 600 patients on average. Some tend to go more, some tend to go less, depending on the preference of the founder, right? And what their lifestyle they would like to be. In my own specific case, I'm really indexing for making care accessible and affordable to patients. So I am not prioritizing being profitable initially. I think this is just going to take some time. And patients, when they're not sure what they should be paying, I offer for them to index it to what their hourly rate is. So, if someone's making $18 an hour, I make that be their monthly fee. And they can only consume so much primary care services, especially in the way that I have set up the practice. And most people really respect any boundaries that, they get access to me virtually anytime. And so no one tends to overstep boundaries or, call me every day or something like that.
As appealing as this sounds for patients, we're so used to using insurance to access care, there's actually a lot of education involved.
I mean, you're kind of the constant underdog, right? And so you have to be educating patients of how this works because people are, fairly addicted to insurance, so to speak, not through their own fault, but this is just how the system has been designed. And if you think about it, insurance is supposed to protect against unpredictable, rare, catastrophic events generally, right? And primary care is the opposite of it. It is generally lower stakes. It's very predictable and it's routine. Often people compare that to, it would be silly to use your car insurance to get oil changes or something like that, right? Things that happen on a predictable cadence. And so I think a lot of it is just a culture in the healthcare ecosystem.
Obviously, changing culture, any culture, is hard, especially when you're alone. But part of what's so striking about the DPC movement is the community they've built around this type of care. One physician I interviewed described attending his first DPC conference and likened it to a religious revival. And while there are obvious benefits to having a community and sense of belonging, a lot of the benefits are also practical. These physicians seem uniquely inclined to help one another as they build up their practices and innovate.
So a lot of DPC groups love helping each other. And so actually on Facebook, there are a lot of private DPC communities, and they're either national or regional or state-based because different states have different local problems that they have to deal with in general, right? And so people tend to help out each other almost mastermind-like.
The community is critical given the challenges of starting and running an independent practice, especially given all the overhead costs that we may think about way less when we're working for a large health system. Here's Katie again describing the financial challenges.
It is hard. And, the cost of your own health insurance as well, right? And, we've got to contribute. Our retirement is all us. And so that's a lot. That's really expensive. And when you work for someone, they're going to take care of that for you. But as we all know, there's no free lunch. And so if you want all of those things, then you're going to have to see 25 patients a day. And you won't be able to get the time off to see your kid's Christmas concert because, you're booked out 3 months already and you can't make that change that quickly. And you just have to figure out, what are you willing to give up for your independence? Are you willing to give up some money? Either maybe your income will be the same, but you have to pay more for insurance. You have to pay more to put in your retirement. What will you give up so that you can be in control? And I think most doctors are starting to look around saying, I think I can give up some stuff so that I can be in control.
Some of the challenges, though, are less financial than they are philosophical. Most concierge and DPC physicians with whom I spoke, particularly those who had left traditional practices, expressed guilt about leaving patients behind who couldn't afford membership fees. On a societal level, though, there's a fascinating utilitarian question that we don't have good data to address. Meaning, are DPC and concierge practices a net good or a net bad for society? If a primary care doctor leaves traditional practice and moves to a panel that's half or 1/10 the size, access to care obviously worsens, and there's more work for the PCPs who are left behind. But what if that same doctor who moves to a smaller panel was instead going to leave medicine entirely? Here's Katie again.
One of the arguments against direct primary care is that it pulls a fully trained family med doctor out of a clinic where they might have, 1,500 patients, right? And I think the argument against that is, for a lot of us who went into direct primary care, we were considering getting out of medicine completely. And so this keeps us in. It also keeps people from retiring as quickly as they might have. And we see that a lot. If you go to conferences, there's a lot of people who just in their maybe late 50s, early 60s, they're thinking about retiring and they look at DPC like, I could get 10 more years out of my career if I do this. And so we can't forget that the burnout is real. And if you can keep as many doctors in medicine, even if they're seeing fewer patients, then that's a win. And you can look at this in the other non-clinical jobs that people are rushing to. The prior auth people or whatever they are at the insurance companies, those jobs are getting competitive because people are trying to leave clinical medicine. That's a problem.
The utilitarian question obviously has a numerical component that could only be answered if we knew how many joining these practices would have left medicine entirely without this option. We don't know that number. But I also think part of the utilitarian question, as counterintuitive as this may seem, doesn't lend itself to math. Because it's about autonomy and the spirit of physicianhood that these doctors are trying to reclaim. So yes, while this shift has immediate consequences that are theoretically measurable, what can't be measured is how this movement might inspire a professional reckoning with the erosion of autonomy that's affected all of us. What happens when the rest of us look around and see doctors who've grabbed the reins of their professional lives and seem happier and more gratified because of it?
If I look around, the happiest doctors that I know are the ones that own their own practices. And absolutely there's stress involved, but when you are in charge of your own schedule, that's really, really nice, where you can say, this is when I'm seeing patients, this is how long my appointments are. This person needs 45 minutes every time, and it will actually happen. Like, that type of autonomy is incredibly powerful.
Here's Paulius also emphasizing his hope for the future.
I don't think the answer is always like straightforward. I wish that the primary care world could be just direct primary care, but you have to work with the realities. And I think there's a lot of knowledge sharing in different communities forming around helping each other navigate the system. And then patients recognize the value, and then, the word spreads, so to speak. So I am definitely optimistic about how things could happen in primary care, and hopefully I'll get to contribute to that movement.
When we think about the loss of autonomy in medicine, we're often referring to what's happening at the individual level between patient and clinician. And I think both concierge and direct primary care practices effectively restore some sense of control. But there's another type of powerlessness that many of us feel when we talk about the system. A sense that it's just too big and complex to change. What's most striking to me then about both of these movements is a rejection of this idea that we have no power to reshape the system. All of these doctors are making a choice to practice differently. This choice, by shrinking panels and excluding those who can't pay, is not a scalable solution to primary care's problems. But I still think it's important to recognize that these physicians are choosing to practice in a way that allows them to be the doctors they want to be. And that is a choice worth paying attention to. I'm Lisa Rosenbaum, and this is Not Otherwise Specified from the New England Journal of Medicine. Next up, we've talked a lot about what's happening within primary care, but there's obviously a lot happening outside as well, including massive technological changes that are affecting not just how people interact with our healthcare system, but where they place their trust. And as always, primary care is on the front lines.
Well, there will be some iconic error that the AI causes. It will become a cause celeb, particularly for people that don't want this to happen for whatever reason. So there needs to be some guardrails, but I think that the potential here is so great and the needs of the healthcare system are so vast that I worry more about hampering it, about putting a straitjacket on it, than I do about under-regulating in the short term.
That's next up on Not Otherwise Specified from the New England Journal of Medicine. Our editor is Debbie Molina. Our producer is Mary Rose Madden. Adam Strauss is our audio engineer. And I also want to thank all of my colleagues at the Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center. They've helped me to conceptualize this season and to identify the most pressing and unexplored challenges facing primary care. My article series on primary care can be found at nejm.org, and our email is nos@nejm.org. I'd love to hear from you.